Hello everyone, welcome to Medica CardioTalks. I am Dr. Dilip Kumar. I am joined today by my colleague and friend Dr. Sanjeev Mukherjee, and we are going to discuss something about TCT 2020 and some recent molecules which have come up in cholesterol management. So Dr. Sanjeev Mukherjee, you're welcome. And could you tell us something about the newer molecules which are knocking at the door of cholesterol therapy and something like bempedoic acid and inclisiran?
Sure. See, thank you, Dilip. These two molecules, I think, are interesting because the data that is coming out is looking very exciting. The first I'll talk about inclisiran. Inclisiran is a molecule which acts through what we call a small interfering RNA. That is the mechanism. So it basically goes and prevents formation of PCSK9. Now, for my friends, just to give an idea, that PCSK9 is a molecule that when it attaches to LDL receptors, which are there on surface of hepatocyte, it prevents, in short, stops this LDL receptors from working. So therefore, LDL receptors are not there. LDL is not getting used up in the liver, and so the level of cholesterol is going high. So PCSK9, there are inhibitors, but this molecule is going to bring down the production of PCSK9. That is the beauty of it. It acts through mRNA, as I said, and it is given sub-Q. Another interesting thing is it can be given once every 6 months. So you give a dose on day 1, day 90, and then every 6 months you can give a dose. Studies, multiple trials in different group of patients have shown an average of 50% reduction in LDL by this single agent. So I think compliance is going to be the biggest issue as far as inclisiran is concerned once it hits Indian market. So that I think I'm very excited to see this molecule come and see its cost. The only side effect they saw was local, that is injection sites, some amount of local thrombophlebitis and discoloration. Otherwise, there were no significant side effects. Bempedoic acid is another new molecule that is going to come. It is acting on the enzyme pathway. That is the first citrate. When it converts to acetyl-CoA, it converts by an enzyme called ACL, ATP citrate lyase. On that, bempedoic acid acts, brings down the level formation of cholesterol and so the LDL levels. And it has been shown that as a monotherapy, it brings LDL down by about 30%. So when you combine it with either statins or ezetimibe, you are going to get an additional advantage. So I think bempedoic acid will be an add-on agent once it comes to the market. And based on cost, I think it will be a good add-on in patients where we are not able to use statins or for some reason we have to withdraw statins. So I think these are two agents definitely we are looking at as when they come to hit our markets.
Yeah, and we feel that especially bempedoic acid, it will be a cost-effective option for those patients who will be unable to afford PCSK9 inhibitors, especially monoclonal antibodies. If we want to go after a target of maybe less than 40, those patients with recurrent acute coronary syndrome. So do you feel this will be cost-effective? Statin plus bempedoic acid?
See, cost, I am not sure how much will it be, but definitely cost I think would be lesser than the monoclonal antibodies at least. But I think it will be an add-on agent. But in terms of reduction, if you see, I think inclisiran looks more promising to me because all trials, it is about 50% reduction in LDL. So I think inclisiran probably, I am more excited than probably an add-on as bempedoic. That is what I will say.
So I think in fact, this is something like inclisiran vaccine against atherosclerosis.
I think so.
Yeah, you give it, take a shot of
yes.
injection 6 monthly and then you are protected. So great. I think these are very exciting new developments in cholesterol therapy. Now we'll move on to TCT 2020 and it has given us very new insights, new trials. So let's start from the imaging perspective. So the first ultimate trial which we will discuss, it has re-emphasized the use of and role of imaging in coronary arteries, when we do some procedures. From the Medica data from US, it shows a dismal 5.7% use of imaging in PCIs. And since we have a lot of evidence with trials showing imaging, reducing the adverse outcome, bettering the results of PCI, the ultimate trial again showed that at 3 years, we can reduce target vessel failure by 40%. So it's a huge benefit. and probably it will push us to use more and more imaging. So what is your
No, I think, yeah, I agree. But I would definitely like imaging to come in, especially in complex cases, chip cases, bifurcations, left main, ISR. I think that is what
especially chip cases, imaging is a must rather. Now, next segment is, physiology based studies, and they have shown that CFR is making a comeback. And with this trial, defined flow trial, they have shown that if the CFR is less than 2 and FFR is around 0.8 to 0.85, between 0.8 and 0.85, still the results are not going to be better if you leave these patients.
And how do you do it?
CFR, I think they will come up with wires and then the similar. So we have not done CFR for a long time.
Yes.
And exciting to see how CFR, FR combined give us better outcome and results in future. Next come the after the PCI, if you see the physiology by IFR, they have shown that the IFR still is less than 0.95 post PCI. Then the results are not good in long term. So I think more and more use of imaging and flow, physiology based assessment.
Yeah, just to give some idea about IFR, if you can, because
IFR is similar to FFR, but here we don't require adenosine to be given. It measures in the wave-free interval. So here we don't, require a maximal hyperemia by medicine.
Adenosine. Yeah. Okay.
So, and third, which is very important trial, which we'll discuss, is Disrupt CAD3. And we all are aware that around 50 to 55% of patients with when we do PCI in calcified lesions, and 50 to 55% patients have a unexpanded stent. A fair amount of unexpansion is there. And the Disrupt CAD3 investigators showed us that there will be 102% stent expansion if we use lithotripsy. And this use of lithotripsy is safe, and it doesn't add to any complication, and it ensures well expansion of the stent. So
now, what is your suggestion? Should we always do imaging prior to?
It depends. I think if you find that basically a very high fluoroscopically there is high evidence of calcium is there, and it is better to do in imaging to just estimate how much if it is 360 degree to more than 270 degree, how much is the calcium burden?
Arc of the calcium.
And if you're going to OCT will give us even better idea about the depth of the calcium, the amount of calcium, the diffuse, how much, the length of the calcium is involved. So imaging will give us more insight, but Disrupt CAD3 has shown that lithotripsy is a very exciting development, and the results are simply jaw-dropping and wonderful. There is also a very kind of hypothesis generating trial which has come up, Prospect and Absorb Prospect, showing that in acute coronary syndrome, non-culprit vessel angioplasty for mild lesions only, who comprise of the lesions comprising of high lipid core or so-called vulnerable plaques. So going after these, mild lesions in acute coronary syndrome, non-culprit vessels, based on the findings of IVUS, OCT, and NERS. So I am not a proponent of this kind of hypothesis or results. Maybe we have to build something more and more facts and more evidence on this, because it is defying all the efforts and studies which we have gone through, and which got through FAME group of studies, differ group of studies, differ studies, courage, ischemia. So it is a kind of a disruptive
thinking process.
Definitely,
yes. Yeah. And so which imaging is forming the absolute, background of this decision making? Is it NERS?
I think the NERS is the most definite, but still you can make out a virtual histology with OCT and IVUS. So maybe NERS first, then OCT and IVUS.
NERS, what does it have?
NERS is like a near infrared spectroscopy, which gives us an idea about lipid cores and exact virtual histology. Okay. Coming to a TCO-STEMI trial, which again re-emphasized that after 3 months of, even in STEMI patients, if you do PCI, after 3 months of monotherapy is good enough. So I think it's a very, this study established again on Twilate and global leaders that days are over for 1 year, probably.
Dual antiplatelets, yes.
There are some interesting studies presented in 2020 on peripheral arterial disease. Like the road is not yet over for drug-coated balloons in BTK lesions, and the IMPACT BTK study showed that the drug balloon is still, has got some promising results. I think we need more and more facts.
Below knee.
And very interesting, direct temsirolimus administration into the adventitia. It is by a bullfrog catheter, delivery system, where a direct this drug is administered into the adventitia. And they have shown that this is a phase 2 trial called Tango phase 2 trial. And what they found was there is a less target lesion failure. So very exciting. I think future will tell us below knee interventions where we feel very pessimistic how the results would be. Maybe drug-coated balloons, Tango direct administration of temsirolimus by this catheter bullfrog can give us open up new avenues.
Yes.
Finally, a word about structural heart studies on structural heart. Studies showed disappointed results, and these are neo-aortic valve from Boston. It failed to show non-inferiority as compared to core valve. And second is embolic protection device. Still, it has not able to show any significant difference in the outcome. In TAVR.
Okay.
So I think we have to wait to have a very conclusive idea that in every patient whether we should use embolic protection device or not. Okay. Maybe selected cases when patient has a CV or something.
High risk probably.
Yeah. And before wrapping up, again a word about what we discussed, what was discussed in TCT 2020 about renal denervation. Okay. There is a newfound enthusiasm, newfound evidence, but strictly from my point of view, and with experts also coming to a conclusion that especially those patients who have accessory renal arteries. So we have got accessory renal arteries, higher nerve plexus around this, more and more nerve plexus. Then we ablate it, you are going to get better reduction in blood pressure.
No, I didn't get it. So patient who has got 2 renal arteries and patient who has got 4 renal arteries.
Yes.
So you are saying that patients who got 4 renal arteries, it is better to ablate there. The results are going to be better than 2 renal arteries.
Because there are more nerve plexus to ablate. So accessory renal arteries, there are more nerve plexus to ablate.
So they also must be targeted.
So if accessory renal arteries, if 3 to 4 millimeter, or larger, they will carry a good amount of nerve plexus if we ablate. Okay. And these are the subgroup of patients. They have shown better results. So my thinking onwards, I will choose those patients because 1/3 of patients have accessory renal arteries. So I will choose those patients who have accessory renal arteries to start with renal denervation. So any further inputs from you, Dr. Sanjeev?
No, nothing. I think that it is definitely hypothesis generating, that NERDS trial, and I think we will be definitely looking at imaging to define a vulnerable plaque and probably trying to bring down the incidence of ACS is something I think probably I would like to look at. And rest, as you discussed, I think they're all very interesting trials and we should all focus on that. Yeah.
So thank you so much. We conclude here and we'll meet again. Thank you again.